All right, guys. Well, today we're sitting down with Dr. Stephen Capobianco. I'm not even going to try because I always call you either Capo or Steve. So,
Exactly.
and we started off air. You can't offend me. So, you know what? I'm not even going to try. And Spencer will tell you I'm worse with logistics or
Capobianco?
linguistics.
Did I say it right?
Capobianco.
Nice job, Spencer. Thank you.
I'm going to try and go. I have to do with an Italian accent. Capobianco. Is that
Even
fair?
better. See,
All
that's
right,
how you do it. That's how you do it.
Capobianco. He's a co-founder of RockTape, and but you know what? He's one of the sharpest minds redefining how we touch, brain mapping, nervous system, shaping pain, movement, human performance. The more I get to know this guy, the more I love this guy, and he is just one big brain with arms and a body attached to it. So, welcome to the show, Steve, and we're just going to call you Capo.
Capo works. I appreciate the attempt, and I appreciate the opportunity to kind of talk shop with you guys.
Ever since we sat down at Pro Sport, it's just, I just have been fascinated with you, and my partner, Dr. Aaron Schneider and Ira, were just huge, big fans of you. So It's just an honor to sit down with you, and the fact you took time. So thank you, bud.
My pleasure. My pleasure.
All right, you've been studying, to kick this off, we've been talking off air, you've been studying about chronic pain, and it's become like a passion for you. And for example, you're discovering that pain isn't not only a tissue problem, but it's also a brain problem. And when someone asks, my back is out, what do you usually think about that when they say stuff like that?
I loved how you set the stage for it. Having a patient, which we've all had, and continue to have, where they come in and say, "My back is out. I have a bad back. I have a bum knee." All of the descriptors, and this is the important part, at least from my experience and what I'm reading as it relates to chronic pain. It's the narrative that we attach to the symptom that actually adds fuel to the fire. And so if you're not paying attention to how people describe what they're experiencing, not, obviously giving you a location saying I've got a bad back or, my back is out, but, looking at those descriptors so then you can dive deeper. And that's really what I've been doing as it relates to the last, let's say, 10 years of my 23-year career, is that I've been focusing on the nuance in between their description of whatever's going on. And that's really where I've been diving into the literature. The literature is really getting fascinating because they're starting to ask those questions. They're starting to get into the weeds as it relates to something as messy as chronic pain.
On that note, you also are talking about, you're looking at even the touch and our sensory spotlight and how when our hands contact somebody. Can you kind of dive into a little bit about how you're looking at sensory and touch differently than we have in the past?
Well, I think the three of us can all agree that the way that we were trained when it comes to chiropractors is we're putting our hands on people and we're manipulating X tissue. That could be the soft tissue if you're a soft tissue practitioner, the joint, of course. And so that was the mindset that I was given as a new practitioner. I was trained as a biomedical, specialist. I was putting my hands on people to move tissue. And the shift as it relates to now performing the same therapies, the chiropractic adjustment to soft tissue manipulation, but it's just a different goal and intent. Probably intent is probably the better way of putting it, is that when I'm putting my hands on someone, I'm starting that communication from hand on body, not even thinking about what vector I'm going to put into the joint or what level of muscle that I'm trying to influence. I'm starting off with, how am I communicating to this person's nervous system, and how does that influencing what they're experiencing? How do we take advantage of touch to make that connection to the patient?
You know what? Spencer and I were talking, I think he was even yesterday, about the new docs coming out. And, you talk about how when you touch somebody, it lights up parts of the brain, the system. Well, a lot of the new docs coming out are using AI, and they're learning, and they're very good, maybe good diagnosticians. But are we losing that touch? And where do you see that going?
Yeah, they can't take that away from us. And I hear a lot of people, especially new docs that are coming out, thinking that AI is going to take away what we can provide. I think that's going to be a challenge because, yes, I have all the tools that we can manipulate or use the innovation that we're getting in respect to medical devices and tools to be able to create a touch stimulus. I'm even seeing these robot massage therapists. Have you guys seen those where it's a table that has connected arms that the robot actually performs the massage on you, which looks amazing, to be honest. But what it can't do and what it can't replicate is the human connection between a therapist, the doctor, and the individual, right? So that part I'm really excited about. I'm actually excited for the new docs that are coming out because they're getting, new information that we didn't have when we were in our formal education. And the new evidence is really saying that the touch stimulus is having a conversation with the brain. When it comes to my content with RockTape, we're always talking about the tape is a megaphone to the brain. It's providing a conversation to the brain that the brain has to now articulate and say, what does this mean? And then the response, the output is going to be hopefully a reduction in pain and improvement in your movement. So touch is so much more nuanced than just pushing a muscle or moving a joint.
Everybody's now searching for that nervous system regulation. They're looking at breath work, they're looking at cold plunges and vagus nerve blocks. And what do you think people are most misunderstanding about the nervous system, especially when it comes to chronic pain?
Well, let's dive into it. I just think the storytelling that can be had by better understanding how the nervous system governs what we experience and how we move, and how the brain is number one job. And I hope this has been communicated in with your those others that you've been interviewing, is that the brain's job is to keep you alive. And the brain isn't as reactive as we used to think, meaning that stimulus and react. It's much smarter than that. And so it's predictive. And so the brain is a predictive machine looking to predict what's going to happen in the future so it could appropriately devise a plan that makes sense, that keeps you alive ultimately. So when it's predicting the future, it's predicting what is a threat versus what is safe. It's like, what direction do I need to move that's going to be away from the threat and towards safety? And that might seem, odd to say, but ultimately every step that we take is a decision that we have to make. Is this a safe step or not? If you're on the edge of a cliff and you're walking around, you're going to walk differently and be a lot more cognizant of the environment around you, because a step could be off the edge versus me walking around in my home where I know where every, surface is. I could do that with my eyes closed and still walk efficiently, because the brain is, again, predicting what is a threat and what is safe. What we're learning is that to be able to predict effectively, you need to be able to perceive. And so perception requires a good map. So we were talking about our devices just before the call. And when I navigate any city, and I travel quite a bit, I'm always relying on my GPS on my phone to be able to navigate whatever environment that I am. And so I always think about this, is that if I'm going down a street that I don't know, and a right turn versus a left turn could be, I'm going down a street that I can get mugged versus going down to a street where I can have a great dinner with friends. Your nervous system is going to really pay attention which direction is most appropriate for you. The same thing happens in our body. We have multiple GPS maps. The ones that are most pertinent to our discussion today for pain and movement is, and I'm going to use the term exteroceptive map, which is basically our human homunculus. If you guys are familiar with the term, you remember our old neuroanatomy textbooks of the description of the body within that part of the brain called the somatosensory cortex. So that is exteroception. And if our homuncular map, our exteroceptive map, is smudged or lacking clarity, your brain's not going to have a good idea of where we are in space. And so when your brain considers moving your bad back or your back that is out a threat, it's going to do what it exactly should do. It's going to protect you. So when you don't have a good map of your body, just like not having a map of whatever city that you're in, your brain is going to protect you. And so the best levers that your brain has to protect you is increase your pain. That's the number one lever that it has because it's the best motivator. But it also will decrease your movement. It'll make you tighter. It'll make you weaker. Those are all things that the brain can do to be able to protect you from what it deems to be a threat.
Hey, Steve, you brought up homunculus. Now, I also want to cater to the fact that some of our viewers are lay people, and you
That's right.
mentioned, I have a question about that, homunculus versus interoception. But, the homunculus was created in like 1937 by some neurosurgeons that would touch areas of the brain, and people would respond saying, oh, I feel that in my, tongue, or I feel that in my fingers. And they mapped it out to how portions of the body or areas of the body would occupy portions of the brain. It was pretty cool. But again, that was from 1937. Now, can you explain some of the, there's interoception you had mentioned about, and then there's somatoception. So can you explain those two and the differences and, what those maps look like so people understand better?
Thank you for reminding me, Spencer, is that let's start first with this homuncular map. And so again, there are multiple maps and I'd like to kind of break them out in more detail, but the homuncular map is really pertinent when it comes to touch, right? Because it's a touch map. Ultimately, to your point, they've been able to map the entire body. And the homunculus is just the name that Penfield, the neuroscientist, gave this description of this basically, little u, that's what homunculus really means, in a part of the brain. And what they've been able to do is map each region. So you know exactly where your shoulder is in respect to your elbow, your lower back in respect to your hips. And the map clarity is critically important for your brain to figure out where am I in space? What's my posture? What should be next move according to what I know where my body is? And so that's the exteroceptive or homuncular map. Now, the ones that I've been diving in so much further, it's because I became aware of it about a decade ago as I started to work with more chronic pain patients and started to dive into the literature to say, what am I missing here? Because we all know that chronic pain is difficult to manage, and the traditional touch therapies from adjustment to soft tissue care to foam rolling, tape, whatever you want to call it, may not be improving their symptoms. So we think that we're influencing the homuncular map, and we are, but it's not making a change. And so I started to say, what else am I missing? And so I found that there are multiple maps in the brain. And another map that I think is pertinent to this discussion as it relates to chronic pain is the interoceptive map. So if we take extero as our outer map, our touch map on the outside of our body, the interoceptive map is what you feel inside. And the interoceptive map is, I can give you examples of when you sense your heartbeat, that's an interoceptive feeling. When you feel grumbling in your stomach because you're hungry, that's an interoceptive feeling. When you have to go to the bathroom, your bladder expanding is an interoceptive feeling. But here, and that means nothing to anyone that wants to know more about chronic pain. But interesting enough, pain is an interoceptive sensation. Mm-hmm. And so understanding interoception in more detail, at least for me, is giving me some extra levers that I could pull with my patients and clients to say, hey, your outer map, your body map is clear. That's exactly what we wanted to achieve, but it didn't make a dent on your pain. So your threat is not coming from your outer map. Maybe it's coming from your inner map, your perception of the pain. So, Terry, at the beginning, you talked about my back being out. Well, just the word being out, what do you think a naive brain would think of something like a joint that's stacked and you say the word out and the brain interprets the out as a threat. Now that amplifies the pain experience because you've put some meaning or a narrative, a negative narrative to the description, right? So I'm glad we came back to this, but that's interoception in a nutshell. There's plenty of amazing researchers in this space, but the one that I would share, anyone that wants to dive in deeper, would be Bud Craig, Craig, and just one of the leading experts in where this map resides. So if the outer map resides in a part of the brain called the somatosensory cortex, S1, the insular map lives in a part of the brain that's much deeper and more primitive called the insula. And the insula it's just so fascinating to me. So stop me if you think I'm going overboard, but the insula takes information from the body, including touch, and it enters the back of the insula. And it's basically, think of it as like a snapshot. It's a snapshot of what that experience is. So let's say my hand is on the person's lower back. They're interpreting this information. Okay, well, this hand is not some creepy dude. Hopefully they don't interpret me as a creepy dude, but not a creepy hand, but it's an expert, a therapeutic or a chiropractor that's been trained that is here to help me. The interpretation, or that snapshot from the beginning of this is touch, now starts to gain some ammunition, some meaning. So from the back of the insula to the front, that snapshot of my hand on the lower back starts with, that feels like touch, feels like a nice touch. It doesn't hurt. And now, oh, it's a therapist that's putting this touch on me. This might be a good experience. Oh, that touch is warm. Warm to me means safety. Like, see what I'm getting at? So as that message goes through the insula, where this interoceptive map lives, you can shape it with your thoughts. And so that was a game changer for me, is that I was saying, okay, well, I could touch them, but if I can coach or cue the patient to start to change the narrative of what they're feeling, that we can actually change the experience. And that's what I've been doing the last, trying to hone, at least for the last 5 or 10 years, is how do I better create a therapeutic alliance with my patient versus just having them be a blob of tissue on my table that I'm operating on.
You pretty much answered my next question about if someone had pain for years and they feel that their body is, they're hanging on to it. They remap their brain. They feel like it's an unsafe place to live. And just to go over one particular example of how touch can help make them feel safe. Like a patient comes into your office and they have, I don't want to just use low back pain. Let's say they have, oh my gosh, their elbow hurts. They have elbow pain. They've had it for years. What would you do that would be different?
Yeah. Well, let's go back to those maps. So I'm still performing, and this is where manual therapy has gotten a bad rap. Manual therapy, and I'm going to include a chiropractic adjustment into that, is it's basically been under attack for the last 10 years, and I'm sure you guys have seen it, where those that are saying anyone that puts hands on people is creating reliance. It's not necessarily mechanically making any change to the tissue, and so I was like, okay, well, I've been in practice 23 years. I feel that some of my manual therapies have been pretty effective, not to everyone, right? And this is my point, that I've evolved from being a traditional manual therapist, let's put an elbow into a psoas, to one that's a little bit more nuanced. And what I want to share with you is how I've kind of evolved my manual therapy. I'm still putting hands on body and using tools to quote unquote manipulate the body, but I'm doing it with a different lens now. So the example of the elbow is a classic one, right? So especially with the pickleball movement that's going on, I'm sure you're seeing it in your area, Spencer and Terry. It's everywhere, so I shouldn't even ask. It's everywhere. We're having a local HOA meeting in respect to the noise associated to pickleball. Have you guys been under that? Have you heard of that?
Not yet, but we see a lot of calf injuries amongst the older folks. But go ahead.
For sure, for sure.
And it can be noisy. So yes, I've heard. Even when they're in people's homes and there is no HOA, it's causing friction between neighbors and stuff.
I'm hearing the same.
They start it at the as soon as the sun comes up, like Spencer time, and they start playing pickleball, and people are, I'm trying to sleep, and it's not quiet like tennis. And Tennessee's
No.
not as quiet, but it's a lot louder.
Yeah, well, I'm running into this now, but I deal with a lot of folks that have had, elbow issues that become more chronic. So let's say that they've gone through 3 or 4 other practitioners, from massage therapists to PTs to other chiros, and they finally come to me and are like, I've had this for 3 years, it's not resolving. Immediately, I'm starting to think, okay, I'm no better than the other 3 or 4. I used to think that I was always, cocky and better, but I'm no better. What I can do is potentially open an opportunity to create some dialogue. And I know that you've had Dr. Joe Lavaca on here, and I learned, Joe was part of my, education team. And I loved how Joe would communicate what he does as it relates to chronic pain. So I've taken some things from him as well, but it's all about starting to make that connection. And that connection starts with the words that we choose. Quite often I'm not as particular about the words that I'm saying if I'm seeing someone that is not in chronic pain. But when I have someone in chronic pain, my nocebo terminology I'm very sensitive to. So if any of your followers don't know what nocebo is, it's the opposite of placebo. And so, like, just saying things like, my back is out, I have a bum knee, I have, bone on bone, those can all be nocebic, meaning that they actually can cause pain, just like placebo can take away pain. So it's a psychosocial, manipulation just by using words. And so I start connection by building that relationship. But to answer your question more directly, Spencer, is that I immediately start with some type of hands-on or touch therapy. And my touch therapy ultimate goal is not necessarily to break down scar tissue or adhesions. I don't believe that to be true, like we were trained to think. Now I'm using the touch to be able to say, how do I improve the Wi-Fi connection between that body part, your elbow, and the maps in your brain? And if I can add to that, there is some nuance to the type of touch that will actually influence different brains. There's almost like a coordinate that you could use to be able to talk to the exteroceptive or homuncular map, your touch map. And then there's another coordinate that you could use to talk to the insular map, the interoceptive map. So those two are like my big 2 that I start with. I said, let's first identify the clarity of your map. Do you guys still use 2-point discrimination?
Sometimes, yes.
Right. So this is what I've got. 2-point discrimination, for those that are not familiar, it's basically, you could do this with just 2 pieces of what am I thinking of? A paper clip, and you can kind of expand it and use it. But ultimately, what you're asking someone to do, if it's the elbow, and I'm going to use myself on screen, but verbally, those that are maybe listening, I'm going to be using 2-point discrimination to see how clear their exteroceptive or homuncular map is. I'm not using it like we were trained as trying to find out what's the sensory dysfunction of X nerve or following a dermatome. I'm actually just saying, in the area that you have pain, how clear is your outer map? And so you could use 2-point discrimination to say, tell me with your eyes closed, of course. I'm asking the individual to tell me, is this 1 point or 2 points? And then we can measure that distance to be able to identify how clear someone's map is.
I haven't done that in years.
Well, Terry, this is what blew me away. Like, again, I've been in practice, probably as long, if, maybe less than you guys, but I'm somewhere around the same realm. I ask this question every class that I teach, and everyone has put this tool away. It's in a drawer somewhere because they're like, I was using it for dermatomes, but it really didn't give me enough information to change what I was going to do. This, to me, if I'm going in to say, I want to improve the clarity of your homuncular map, your touch map, how do I know if I'm making a significant change other than seeing a change in their pain or their movement, which is important. But as you know, chronic pain takes time to be able to change the perception of pain. And if I can show someone that when we started, even in the same session, I might start at they're 80 millimeters apart. Those 2 points of contact are demonstrating that that person doesn't have a very good map. You should always measure it to the asymptomatic side, just like we've all been trained to do. There is normative data for every part of your body as well. So if you wanted to measure your lower back map compared to the mass, you can actually look at that, and it ranges around 40 to 44 millimeters of separation. That's considered, normative, discrepancy. But when it comes to chronic pain, that map becomes blurrier and blurrier. So your ability to sense 2 points becomes compromised. So job number one for me with my touch therapy, I want to communicate that level of touch. So that's when you're taking advantage of A beta fibers, the fast traveling, mechanoreceptors in your skin and fascia. So that's my first way. So I'm going to use tools. I'm going to use my hands. I'm going to use whatever I have that's novel enough to get the brain's attention. And then we're going to recheck. And like I said, you can make that change within one session. Does it last? Probably not. But it's a starting point where you can say to the patient or client, today we did some good work. We improved the clarity of your body map from 40 millimeters to 30 millimeters. And they're like, but my pain is still high. And I was like, I get it, but we're making movements towards changing that by improving your overall map. So I give them a goal. Let's focus on making this as clear as possible. Let's shine that spotlight. So that's the first way that I would start, Spencer, is that I would start with clarifying their outer map. I'll stop there and see if you guys have any questions before I move to the inner map.
No, that's beautiful, because the fact that you're measuring a difference pre and post, and it proves to the patient that something's changing. So
that's
continue.
Right. That's
continue.
Right.
That was great.
Listen, chronic pain is messy. Shoot, humans are messy. So like, if we're not paying attention to the human that's presenting, that is clearly that they just don't know where their body's in space, and you could do that. There's multiple other ways I should imply is that you could do movement screening, and looking at how someone accomplishes a specific movement can give you some sense of, are they confident or not in that movement? That's not a structural identification. I'm actually looking at how confident are they moving through that range of motion? Because if someone's moving through and they're very cautious, that's information that I'm going to take in respect to their map, not necessarily, it's scar tissue or it's a joint restriction. I can go in and work on those, but I'm looking at how clear their map is according to their movement, and then using something as simple as 2-point discrimination. So that's the body map or touch map component, and quite often. Go ahead.
Sorry, quick question in regards to that. Are you able to also identify someone's chronic pain as, well, you started to allude to it before. I think I read in a psychology magazine that people have a tendency to have a psychological overlay, which in regards to their pain, and it suddenly becomes their identity or not, or chronic pain becomes their identity. And you have people that come and go, yeah, like, and it's like, oh, nonchalant, yeah, my back's been hurting for years or something like that. And then you find out that, what would life be like if it didn't hurt? How do you identify whether it's, you remap the brain, and its sensory input versus someone who's psychologically owning it?
It's a perfect segue. You couldn't have done it better, at least for me, to kind of tell the rest of the story, because honestly, the one component that I started to suggest is a good way to create an improvement in your touch map doesn't necessarily solve all the problems. If it's just that you'll see the improvements, and that person can start to sustain more changes durably. But those that say, yeah, I'm seeing some change, but I'm not seeing enough, that's when you have to dive deeper. And when I say dive, I mean we do need to dive inwards now. And so how I now shift my gears in respect to what I'm trying to influence, I'm not going to be using touch that's focusing on A beta fibers, all the fast traveling mechanoreceptors that speak to the homuncular map. Now I'm going to be changing the dosage of how I'm touching them, the speed. I'm going to give you all of these metrics because they're important. Is that my touch now changes? It becomes much lighter, and it's taking advantage of body temperature. What they're finding is that we can stimulate a certain set of receptors by human touch. They really got most of this information from mother-child interface of why do we put a baby on mom's chest, bare chest, immediately after birth, because they see that survival rates go up. It's not just an immune function, which a lot of it is. It's the neurological connection immediately after birth. It just blows me away of what I'm learning about primates and how they interact using touch, and mother-child interactions have now given us the opportunity to learn as therapists that there's a certain form of touch that we can provide, which is actually been labeled as interoceptive touch. So interoceptive touch, if our goal is to now start to communicate with a different part of the brain, we're going to be using, like I said, lighter touch. And they actually give you kind of a level of touch. If you're going to rate pain from 1 to 10, you can rate pressure from 1 to 10 as well. So you're trying to stay within what a patient will perceive as 1 to 3. So it almost seems insignificant. When I get this type of treatment, because I've been conditioned to think that you need to literally strip out my psoas with your elbow, that's like a 9 or 10 on that list. 1 to 3, most people would say, this is not even giving me what I'm looking for. So you have to make sure you're coaching them as you're doing this type of touch. So that's number one, is pressure. Speed also matters. They call this caressing touch. And again, taking from mother-child primates when they groom each other, there's actually a speed that's been shown to be most effective to stimulate these receptors called C tactile fibers, the letter C tactile fibers. So C tactile fibers, we would have learned it when we got trained, and I'll speak for myself, as nociceptors, right? But these C tactile fibers have dual multifunction, actually, and one of them is to receive caressing touch as a safety mechanism. Why do we feel better when our mom is rubbing our back when we're not feeling well? Because we're stimulating these C tactile fibers. There's a sense of safety that's literally flooding your insula, and your insula says safety, 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 and then the nervous system calms down. Well, think about this with chronic pain. They're threat, threat, threat. My back, when I bend back, that's pain, that's a threat. When I cough, I have to brace myself because that's a threat. When I sleep, I can't sleep on my left side, so I have to sleep on my right side. That's a threat. So if you can change their experience by using this type of safety touch, coupled with movement eventually, you can actually rewire the insula's snapshot picture of that everything is a threat to now it's safe. So that's the part that I know I may not have articulated well, and I'm welcome any question, but interoception is a different form of touch coupled with cueing, and that's the part that I'll kind of expand on, but I'll see if you guys have any questions on what I've said so far.
Yes. We have a variety of patients, and if I did a touch that was between, or some soft tissue or light skin work on skin that was between 1 and 3, they would think I'm not doing the job, because they talk about trigger points and knots in the muscle, and you got to get in there and pulverize it. That's right. What do you say to those folks?
Dude, it's not easy, but again, think about what chronic people go through. It's not like if you're the first that they're seeing, then you might have a different strategy. And I could start to peel away at the onion, where to say, I want to meet you where you're at. And I get this from Dr. Lavaca, is that he's the master communicator. And he says, well, Steve, if someone's coming in expecting you to strip out their psoas, strip out their psoas. Because the expectation's there, but at least you could say, we're going to do a pre and post. If we don't get durable change from that, hopefully that opens up an opportunity, a door that you can have a different conversation next time. And maybe it's weeks down the road, right? But I mean, now you say, all right, well, we're going to be kind of decreasing the amount of pressure now, and we're going to be doing this strategy. Here's what we're trying to do. And I use a whiteboard with all of my patients, and I draw shitty pictures, and we laugh about it. And I'm trying to explain what I'm trying to do to their brain. And I make this phone line connection if I'm talking to an older dude, or Wi-Fi connection to a younger population. But I want them to understand what I'm trying to do. And so that allows me to say, okay, today's going to be a lot lighter, but this is what we're trying to do. Let's check and see if we make a change. So give them some objective measurements that say, man, that was pretty effective. And so it gets buy-in. So the last lever that I pull is the interoceptive lever, because it's the trickiest. It's tricky for the patient mostly because they've been so disconnected from their body for so long, and the therapist. I know I wasn't trained to, act as the bartender or the therapist, the psychological therapist. I'm a manual therapist. I do touch therapy, but I've learned over the last few years of how to do it. I think seamlessly, but just more authentically is probably the best way to do it. Saying, okay, I'm going to be touching you. This is lever 3, mind you. I went deep, for a week, let's say, for example. I went lighter, trying to improve someone's exteroceptive or homuncular map. And let's say I'm on week 3 and I want to do a 1 to 3 in pressure. They're already set up to understand what I'm trying to achieve. And so 1 to 3 now makes a difference because I've explained why it makes a difference, what our goal is to communicate to this part of the brain. But this is the last part that I definitely want to share with you, is this is where you have to ask them to be an active participant. They're no longer just a piece of meat on the table. Now I'm saying, okay, I'm touching you. Where am I touching you? And they're like, my back. All right. Is it your right side or your left side? This is lateralization. This has been researched in saying chronic pain back sufferers have difficulty identifying, right or left. They have difficulty identifying pressure. So you're asking these questions. Am I on the right side of your back, the left side of your back? Am I moving clockwise or counterclockwise? All of that helps to shine a spotlight on that part of their brain, their body, in that part of the brain. And then we go another step deeper, literally saying, okay, my hand is, and I ask them to close their eyes, and you guys can even envision this, or who's listening to this, is that my hand is a boat on top of water. And you are diving under the water, and you're a scuba diver, basically in the water. Looking up at the bottom of the boat is my hand. And so I'm giving them, pictures to visualize. And so they're closing their eyes, they're visualizing what I'm telling them to think about. And then I say, okay, you're scuba diving in this water. Is it warm or is it cold? And then they're like, I guess it's warm. And there's no wrong answer. This is the beauty of this exercise. Now you're asking them to interocept, right? So which most people haven't done majority of their lives. So then you ask more cueing questions. Do you feel like you want to swim towards that boat or my hand or away from it? And that gives you an idea of their sense of threat. So you're not only asking them to verbalize it, but you're going to see how do they respond. I didn't look at a patient's eyes. I'm really ashamed of saying this, but probably 10 years of my career, most of my patients were face down or facing away from me. I never looked at someone's eyes. I couldn't tell you what their eye color was, or, because I didn't focus on it. But the eyes are a great window into what you're feeling. So I start to pay attention to their pupils, and they can tell me a lot of information. If you are in high threat, they're dilated. If you're in safety mode, they're more constricted. So I'm looking for all these cues. I'm giving them ways of kind of articulating what they're feeling inside. I ask them to say, what shape is your pain? Some people say, what a ridiculous question, but I'm asking them to just depart from just naming it, but to actually now describe it. Is it a beach ball or is it a golf ball? Is it spiky or is it smooth? And you guys might even be thinking that, Steve Capo, you've lost your friggin' mind. But I'm telling you that the research supports this idea of interoception that can be manipulated with touch, the light touch, soft touch, slow touch. but also by having someone mindfully pay attention. And that's where I'm using the term for the first time. It's basically mindfulness, but you're guiding them around the experience.
Woo, man.
I
Interesting.
know, right?
I have a question that, okay, interoception. I've been wanting to ask this earlier because you mentioned something about the kinesiology tape, or in your case, RockTape, and the fact that interoception gets sensory feedback from heart, lungs, kidneys, so on, but probably one of the biggest organs in the body is the skin. So it gets all that information. And for years and years, whenever I would use that tape on someone's injury, it was for the purpose of what I would. Now I look at it and I think, why did I describe it that way? As a Band-Aid for the muscle, or the ligament or tendon. And it's only recently that I would love for you to describe why you would use tape, because I have a feeling I know what the answer is, but go ahead.
Well, I'll speak it just like I do it every day with patients. It's like, it's a spotlight on the area. I'm shining a spotlight on a blind spot that you have within your brain. So like, you can't see your knee. Your brain says, well, why would I let you move that knee? So the tape is basically shining a spotlight on the area to bring it to its awareness.
Have you always known that, Steve?
No, dude, I was trained just like you. I initially learned kinesiology tape from Kenzo Kase himself. And Kenzo is the chiropractor, Japanese chiropractor, very strong accent, definitely 30 years ago when I learned it. And so I was trained as a biomedical, practitioner. I was moving muscles, I was taping ligaments, and all of that has been relatively debunked. And so we have to kind of lean on what the research is telling us. And it's basically saying this in multiple ways, that we're influencing the nervous system, and that includes an adjustment, soft tissue manipulation to a strip of tape.
I have to say that the concept was brought to my attention about 5 years ago, when a patient who'd been a patient for like 11 years now, she had a history of brain surgery and had other multiple surgeries, and always wished that she could be a ballroom dancer. And this is in her 50s. And I said, I'd been working on her and made incremental improvements, until I said, you know what, I'm gonna use this tape to provide sensory feedback to your brain, because, and I remember putting on her right quad and left IT band, and she could not do it. She won ballroom dancing competitions, and required that tape to be put on because it gave her a sensory perception that nothing else would.
Right. That's how, that's how we teach it, because, it's evolved. And so I know that we're running up against it, but I mean, I've evolved even our description of how to use RockTape, because that's the brand that, that I had involvement with. But just in respect to how I would communicate it, it was more of a myofascial. We're influencing the fascia and the muscle ligaments. Then we started to talk about how it's stimulating certain mechanoreceptors. Well, great. Where does that information go? It goes up to where your touch maps are. So we started communicating about exteroception, or improving your touch map. Then we started learning more about how touch, including tape, can influence different, systems as well, including the insula for the interoceptive map. What I'm sharing with you today is that it all comes down to dosage. If it's lighter, it's more likely going to be more influencing the insular interoceptive. If it's faster or deeper, it's typically more touch map. So having this information, definitely as a practitioner, gives us, more direction of what we could be doing with our patients and clients. And then when it comes to the patient, those that have chronic pain, and I'm a chronic pain sufferer. I played collision sports most of my life, and so I'm reaping the effects of that now. But the homework that I do is the same homework that I asked them to do. I was like, you need to take ownership of the narrative that you're giving yourself. We don't, would you talk to, and this is almost like therapy that I'm providing others that I've received is that, would you talk to your best friend the same way that you're talking about your shitty back or your crappy shoulder or your bum foot? Like, words matter and thoughts matter. And so I start to kind of become more comfortable with the conversation, saying, I'm putting a strip of tape on you. This tape is going to help improve your awareness of where that joint, that body part is. But I also want you to think about this tape as your safety net. I want you to think about this tape as your best friend that's going to be there whenever you need it. To going back to your point of your ballroom dancer, is that they start to attach meaning, positive meaning to that strip of tape, especially if it's like a specific color that they like. I used to make fun of colors, saying colors don't mean anything. Well, I've really taken that back. I said, well, if someone is connected to this color versus this, which I always wear black, I probably would respond more favorably psychologically to this than I would this, right? So colors do matter in that case. But my point is that how we communicate this should change from the information that we get.
It's funny because at Miami Dolphins, they denied using any kind of tape anywhere because, and of course we were given reams of different brands and companies and so on.
Sure.
And it was because players were using it as a cool look, as like pinstriping on a car. And so they denied it altogether. But you're right. It definitely gives you some feedback of safety, and provides a sense of image that gives you an empowering image.
Yes. And so that it was Peyton Manning that said this, is that when he was going through, and I think it was either his neck, I'm pretty sure it was his neck injury, where he was talking about his disconnection from his team, his peers. So what he decided to do is that his rehab, as you know, Doc, is that you're going to be doing that in a rehab room. It was separate from the players. And so he actually brought most of that therapy into where all the players were, because he wanted that connection. But he would say, and this is why it caught my attention, he talked about the strip of tape that he had on his neck post-surgery was basically his social identifier. It allowed people to know that he is actively working, training to get back with his team so he can support his team. So the tape became the kind of the identifier. I thought that was an interesting way of putting it, which I never really thought of until he brought it up.
There's a conversation about a threat inoculation. I think Mosley and Butler had brought up something like that. I know that's near and dear to you, but you've described a little bit of it, or you've described a lot of it, but threat inoculation, can you go over what how that is interpreted by you?
That's my new, and I can answer it pretty quickly. That's my new definition of manual therapy. It's less to do with the mechanical effects that we think are occurring, and more that I'm using this to decrease the threat of the nervous system. Multiple ways of testing for that, and then using that kind of neurological window that I just opened up to now take that individual, if indicated, from passive to now moving. None of this stuff that I'm talking about generally is long-term, meaning any type of manual therapy has been well documented that you'll get short-term benefits, but they don't generally last very long unless you attach it to some type of meaningful movement. So you have to load it. And so I'm a huge proponent of manual therapy plus manual therapy, and because you have to be doing other things. So threat inoculation is, if I could use let's say, interoceptive touch, a very light touch to decrease your threat, awesome. Let's now get you off that table and let's start having you move at whatever level is indicated for them. So that's what I mean by threat inoculation.
I don't think the audience realizes how touch in certain areas of the body can be so powerful and so sensitive that you have to be masterful at realizing. I was taught through, I took courses in neurolinguistic programming that if, when a patient walks in and they're upset and you put your hand on their back to console them, you're reinforcing a sense of whatever they're coming in with that's depressing or hurtful by,
Yes.
like Pavlov's dogs. You put your hand on their back, you go, no, everything will be all right. We have to be so careful not to fire off triggers that are negative. So
Yeah.
for what you're doing is much more science-based and intentional, that I don't want people to think that it's just so simple to do that.
Your term of intentional is probably the biggest part of this conversation, is that yes, the intent has to be there. You have to communicate that intent. To your point, is that someone comes in that's expecting deep tissue, and I'm giving them this type of slow caress-like touch that might not be interpreted. So you have to educate along with your touch. And so the intent is just telling them exactly what we collectively are looking to achieve. And so that just opens up the opportunity. Listen, people came to see me. I'm 235 pounds. They came to see me because they wanted deep. And I would give them, like I said, what they wanted. But if we didn't get the outcome, I hope any practitioner would say, well, okay, that didn't work. What else can we do? And I'm just sharing with you that I feel that this interoceptive, component of the discussion, definitely when it comes to chronic pain, is something for both the doctor and the patient to consider. Because again, I do homework every day. I will journal around what I'm feeling in respect to my pain. Before, I just used to just ruminate about it. It's like, damn, my friggin' back is just killing me. I wish it would go away. I wish I could just, get away from it. It was always the enemy. And so part of my therapy is journaling it on paper. When I feel like crap, I rage on the page. I get it out. I tell the same thing to my patients. I was like, you need to get your narrative out of you and on paper. And it's a good starting point. So those that are willing to do that, they do. Great. That's an interoceptive exercise. I ask them to mindfully move. When you're eating breakfast, I want you to think about every move. That's an interoceptive lever that you can pull. Meditation is a big one, sometimes kind of charged because some people don't want to think that they're meditating, but meditation is another interoceptive, homework that you can provide. So that to me is the next wave of therapy that we can provide those that are in chronic or persistent pain.
Steve, you talk about, the brain and chronic, and you also talk about manual therapy, but there's a fine line of when patients actually could become dependent on it versus
Very
empowered.
Very
And how do you create this resilience of creating a patient who doesn't need you forever, because sometimes they get attached to their chronic pain and now you don't want them to be attached to you. So how do you empower this patient?
Yeah. Simply education, explaining, like, again, Spencer, you brought up the patient that just wanted tape on their body. I've had many athletes that once they see the benefit, that's basically their lucky pair of underwear that they wear forever. So you need to be able to explain what you're trying to achieve, what that duration of time should look like, and that we're moving towards this end goal, which is your ownership of your own body. And that's where movement comes in. Like if I'm not attaching some type of movement as part of their manual therapy in this case, then I've missed the opportunity to make long-term change. So it's ultimately education and then giving them ownership of their own movement.
I refer to crutches as a crutch that you get rid of. You're not going to walk on crutches for the rest of your life. We're just using it to facilitate change. And that's how I oftentimes.
Well said. Yeah.
Well, I think Courtney even mention with everything, what's the end game?
Orthotics. Yeah.
Yeah. But if with anything, when you ask what's the end game, and I think we need to always start with patients going, here's what our plan is, but here's where our end goal is. And
yeah.
I think
Couldn't say it better. That's exactly what it is. And so I'm a manual therapist, and I don't shy away from it. I don't hide from it. There's plenty of evidence that says that it's effective, but most of it is short term. But that short term window is super important for someone that is in chronic pain, that I can make a change on the table in real time and then ask them to move because I have a window of time that is safe for them. Going back to Mosley and Butler, Spencer, they talk about SIMS and DIMS. Are you guys familiar with that term? Those terms? They're acronyms. Safety in me is SIM and danger in me is DIM. And so they basically talk about this model of whatever therapeutic intervention can take someone from thinking that there's danger in me, my bum knee, to safety in me. That small little window of time provides opportunity to make that change longer lasting. So I love the Sims DIMS concept. Is like, my goal today is take away danger and let's make you more safe so then you can start to move more effectively and efficiently.
Love it. In the last
I know,
few
right?
minutes,
It's good stuff.
Yeah, no, really, this is great stuff. In the last few minutes of our show, we go over rapid fire questions. I got 5 of
Oh boy.
them, and some of it has a lot to do with what you do, and some of it has nothing to do with what you do. So if you're
What are
ready
the game rules like?
the game rules are they're rapid fire. So I'm going to throw it out to you, and you got to give it in a brief
In
answer.
response. Gotcha.
If one word is cool, maybe we can take a few more. So we're ready.
Yes.
All right.
Yes,
If
sir.
you could teach, question number 1, if you could teach every human being one skill to reduce chronic pain, something that you could do daily, what would that be?
Physiological sigh.
Fi-
Look it up. Look it up. So if I'm staying rapid, physiological sigh, look it up and you'll find a great thing that you could do every day.
Like a sigh, like S-I-G-H.
Can I dive in deeper?
Yeah.
Well, hell yeah. Now I want to know.
Now I
I'm
wanna
going to
know.
look it up.
Physiological sigh. Some will call it the intentional sigh. This is how it's done. If you guys want to do it along with me, great. It's a blow out your air on the count of 3. 1, 2, 3. Normal breath in for 3. At the top of that, quick sniff in, and then exhale 7 seconds out. So if I repeat that, it's a normal inhalation through the nose, 3 seconds. At the top of that inhalation, you're going to sniff in, sometimes twice, and then it's a long exhalation out. So that physiological sigh has been demonstrated to decrease threat, ultimately, if you're going to take it for like a global description, but it takes a sympathetic system into parasympathetic the fastest when it comes to breathing tactics. So if you have someone in chronic pain, they're always on sympathetic because they're always trying to get away from the threat. So you're using this breath to bring it to more into parasympathetic. It's an easy thing to do.
Love that.
That's a good one, huh? I know.
Yeah. Question number 2. What's one personal belief or habit you have that most people would never guess about you?
I like classical music.
Ooh, really? Do you have a favorite?
I love this look. Did you see it? Like he went, oh.
The classical would be, I'm Italian, born and raised, and so it would be like Pavarotti. Pavarotti would be the top of my list. Let's start with that one.
Nice.
So opera, classical music, but that genre.
Vestia La Juba. All right, very good. Love that. In one sentence, you
Yes.
helped build a global education and product platform for RockTape. What's the biggest moment of doubt you had in building that, and how did you push through it?
Resolving my anxiety to be right all the time.
Oh, interesting. Okay, you were actually wrong at some point in your life?
Of course, many, many times.
Fantastic. Question number, 4. If you had to describe in one sentence why you get out of bed for this kind of work, not the science, not the title, but the impact of people's lives, what would it be?
I actually have it tattooed on my arm. It's a phrase called Ancora Imparo. I share it at all of my slides. Ancora Imparo apparently was said by Michelangelo in his late 80s. And what it means in Latin, or translated from Latin, is still learning. So I get out of bed because I continue to want to learn. Ancora Imparo. Good one.
That was great.
Yeah.
All right, last question, number 5. Steve-O, you've been at the forefront of evolving pain science and manual therapy. If you could rewrite that story the world tells about pain and movement 10 years from now, what would it be?
Our bodies are resilient. I'd stop right there. I don't need to add to it. It's exactly what we're trying to do. Our bodies are resilient.
Beautiful and true. That is great. Oh, this was a very good program today. Thanks, Dr. Capobianco. Oh, and that was great. Thanks, Steve.
That was fun.
Appreciate it, guys.
Thank you for listening to today's episode of the Crackin Backs Podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.